Hello, my name is Ailsa Butler and I'm an author on the Cochrane review of electronic cigarettes for smoking cessation. Today I'm going to talk to you about the results from our latest update to our living review published in January 2024. This work is supported by Cancer Research UK and the National Institute for Health Research. The first and last authors on this review are Nicola Linson and Jamie Hartman-Boyce, and we have no conflicts of interest to declare. So what is Cochrane? Cochrane is a global non-profit organisation. The best available evidence is brought together, systematically reviewed with an emphasis on quality assessment. We bring together the evidence and combine the results to see what they show. We also consider how much we can trust the results. This evidence helps to improve knowledge and to feed into healthcare decisions. Cochrane methods are considered gold standard. Healthcare providers, patients, carers, researchers, funders, policymakers, guideline developers worldwide use the results of Cochrane reviews to improve their knowledge and to make decisions about healthcare interventions. Our Cochrane review of e-cigarettes for smoking cessation, with support from Cancer Research UK, became a living systematic review at the end of 2020. Living reviews are particularly well suited to topics where there's an uncertainty in the evidence and new evidence may strengthen or change the existing conclusions. We run searches monthly and publish the links to new evidence monthly on our webpage and in our briefing documents. Our reviews are updated whenever there is new data that might change, strengthen or weaken our existing conclusions or relates to new comparisons or outcomes. More evidence has emerged since the last update and some of our conclusions have strengthened compared to the last update of this review. This is the fourth update since transitioning to living review status. The objective of this review is to evaluate the safety and effect of using e-cigarettes to help people who smoke achieve long-term smoking abstinence. We look at studies that include people who smoke at baseline and either randomise them to an e-cigarette or control condition or give everyone in the study the same electronic cigarette intervention. Randomised control trials are considered the best way to test for effects of treatments, and so the results I'm focusing on today come from the results of those trials. We look at any studies that report smoking cessation at 6 months or longer, or any measures of harm at 1 week or longer. This review includes a number of different comparisons and a lot of data, too much to cover in a short presentation, and here I'll focus on our primary comparisons and primary outcomes. I'll turn first to our primary comparisons. We're interested in the effect of nicotine e-cigarettes compared to traditional nicotine replacement therapies, and by this I mean patches or gum. The comparison of nicotine e-cigarettes versus behavioural support only or no support. So these are studies where everyone in the study, that means all the groups, receive the same amount of behavioural support. This could be counselling or no intervention, and then one group also receives nicotine e-cigarettes. We are also interested in the comparison between nicotine e-cigarettes and non-nicotine e-cigarettes, sometimes referred to as placebos. I will focus on our primary outcomes, which are cessation or quitting smoking at 6 months or longer, adverse events and serious adverse events at 1 week or longer, and those are as defined by our study authors. Our new review covers searches up to July 2023. We search 7 electronic databases monthly, we contact researchers directly, and we search trial registries and conference abstracts for ongoing studies. In this update, we now have 88 included studies. 10 of those are new to this particular update. 47 of them are randomised control trials and include over 27,000 participants. Most of the studies are conducted in the USA or in the UK. 25 of them exclusively recruited participants not motivated to quit smoking, which explains low quit rates across arms in some of these studies. 3 of these studies now exclusively recruited dual users, so people who are vaping and smoking at baseline, and where reported of the studies that we included, 31 used cartridge devices, 34 used refillable devices, 4 used a combination of cartridge and refillable, and 7 tested pod devices. So here are our outcomes. In these forest plots, the vertical line drawn at 1 is a line of no effect. There's a red arrow to show this. If the data falls on this line, there's no difference between the comparisons. When we looked at nicotine e-cigarettes compared to nicotine replacement therapy, we have high certainty evidence that nicotine e-cigarettes lead to higher success rates for quitting smoking at 6 months or longer compared to nicotine replacement therapy. High certainty evidence means that we think that further studies are unlikely to change our effect estimate in a way that would alter its clinical interpretation. When we compared nicotine e-cigarettes to nicotine replacement therapy and looked at non-serious adverse events, we have moderate certainty evidence of no difference in adverse events between arms. In terms of serious adverse events, again, there's no clear evidence of a difference, But here this evidence is low certainty because we simply don't have that many studies, and in those that we don't have that much data. We have even fewer studies and less data for serious adverse events than for adverse events, and that's why we have low certainty evidence here as opposed to moderate. Turning to our second comparison of nicotine e-cigarettes compared to non-nicotine e-cigarettes or placebo e-cigarettes, we remain with moderate certainty evidence of more people quitting smoking with nicotine compared to non-nicotine e-cigarettes at 6 months or longer. Again, the reason there is moderate and not high certainty evidence is imprecision. There are not that many studies and not many events. In order to move towards high certainty evidence for this outcome, we would need more studies showing the same thing. For adverse events, we have moderate certainty evidence, again here of no difference in adverse events between nicotine e-cigarettes and non-nicotine e-cigarettes. We also did not find any evidence of a difference in serious adverse events, but here the certainty of the evidence was low. Again, this is because there are very few studies with fortunately very few participants experiencing serious adverse events. But what that means is statistically it is very difficult for us to say if what we're seeing is due to chance or reflecting the underlying truth in terms of the impact of these interventions. So finally, we compare nicotine e-cigarettes to behavioural support only or no support. Here all participants receive the same amount of behavioural support. This might be no intervention or also a behavioural intervention such as counselling, and one arm is randomised to also receive nicotine e-cigarettes. For this comparison, again, more people quit smoking at 6 months or longer in the nicotine e-cigarette arm than in the comparator, but here the certainty of evidence is low. This has moved from very low to low for this update as we have more evidence for this comparison. The certainty of evidence is low partly due to risk of bias. The comparisons are unblinded. The people in the nicotine e-cigarette group know they're receiving more support than people in the other group. The people in the comparator group then know they're not receiving nicotine e-cigarettes. According to the way we evaluate risk of bias in Cochrane, this means that these studies are considered to be at high risk of bias. When we look at adverse events of 1 week or longer, we have low certainty evidence of more people experiencing adverse events in the nicotine e-cigarette compared to the behavioural support only or no support arm. Again, there are not that many studies reporting data and the same risk of bias issues. We have very low certainty evidence of no difference in serious adverse events. Here again, there are risk of bias and imprecision issues when we compare nicotine e-cigarettes to behavioural support only or no support. All Cochrane reviews end with implications for practice and implications for research, and these are important and I will read these out. So, as I have shown you, the evidence suggesting that continuing e-cigarettes can aid in smoking cessation is consistent across several comparisons, and we have high certainty evidence that compared to nicotine replacement therapy and nicotine e-cigarettes increased quit rates at 6 months or longer. There remains moderate certainty evidence that e-cigarettes with nicotine increase quit rates at 6 months or longer compared to non-nicotine e-cigarettes, and there is now low certainty compared to very low certainty at the last update, evidence limited by risk of bias that e-cigarettes with nicotine increased quit rates compared to behavioural support alone or no support. Issues with risk of bias, a small number of studies, and differences between studies preclude strong conclusions regarding the effect of nicotine e-cigarettes when added to NRT, but the data available suggest a benefit. None of the studies included, which were up to 2 years, detected serious adverse events considered possibly related to e-cigarette use. The most commonly reported adverse events were throat and mouth irritation, headache, cough, and nausea, which tended to dissipate with continued use. In some studies, reduced toxin concentrations and biomarkers of harm were observed in people who smoked and switched to vaping, consistent with reductions seen in people who stopped smoking without e-cigarettes and other studies. So we have a lot of implications for research. More research is coming out every month, and we would like to thank all the researchers and participants who are contributing to this research. We conclude that further trials need to do a number of things, and we are aware that some of these are easier said than done due to funding constraints. Ideally, they would measure cessation at 6 months or longer, use active comparators, assess safety profile for as long as possible, be powered to detect differences in safety outcomes, present safety in both absolute and relative risk terms in comparison to the risks of continuing to smoke tobacco, offer recent devices to participants with good nicotine delivery to be most representative of what will be on the market at the time the results are released. Data on pod type e-cigarettes are particularly lacking, and collect data on participant device types, nicotine strengths and flavours throughout the trial, and also provide e-cigarettes in a way that would be used in real-world settings. Further reviews using the best available methods need to investigate all of the other issues around e-cigarettes. Here we're looking at their use as smoking cessation aid in people who smoke at baseline, but of course there are lots of other questions, including youth uptake of e-cigarettes. So, we search for evidence monthly for our living systematic review, and if you are interested in further information, please see our briefing documents, our podcast, the full review for more detail on everything just presented, secondary outcomes, other comparisons, data from uncontrolled studies, and comparisons with other reviews. This link will give you access to all of these sources of information. Thank you for listening.